A very good morning to all of you. I am Dr. Tapas Mohanty, junior resident from Grand Medical College and JJ Group of Hospitals. I would like to present a study to for assessment of radiological and functional outcome of plate augmentation and nailing in case of distal third femur shaft non-unions, which were previously operated by cephalomedullary nails. When the non-union in case of femur shaft fractures, particularly in the isthmal area, the non-union incidence is quite low. But when at the metaphyseal diphyseal junctions or the non-isthmal areas, the incidence is quite higher. So various treatment options that has been described in the various literatures that include dynamization, exchange nailing, where we remove the older nail and put a larger diameter nail, and removal of the nail and re-osteosynthesis using a plate, exchange nailing and plate augmentation, iliac rope external fixators are also used. In our case, we included 15 patients who were aged from 18 to 60 years with distal third femur shaft non-unions, who were previously operated for distal third femur shaft fractures in our institute or elsewhere. Patients presented to us with intermittent thigh pain and restricted knee range of motion. And we excluded the infective non-unions by doing ESR and CRP. After optimization, all the patients were taken into the OT table. Previous implants were removed. The non-union site was approached through a lateral approach. The non-union was resected. Fracture ends were fashioned off, and the proximal and the distal fracture sites were singled. The fibrous membrane was removed. And then in a retrograde manner, we put a intramedullary nail, and after adequate rimming, then a lateral plate was in a form of 3.5 DCP, was augmented laterally. Wherever we put unicortical and bicortical screws. All the patients were bone grafted by cortico-cancellous bone graft from ipsilateral iliac crest. Post-operatively, all patients were mobilized with full weight bearing with the help of a walking aid on the starting from second post-operative day. Here is an example where a 23-year-old male presented to us with implant failure as well as distal femur non-union. We went ahead with the removal of the older nail, put a retrograde intramedullary nail and augmented with a lateral plate. And bone graft was also done. At 6 months, we can see there is incorporation of the bone graft. At 12 months, there is consolidation at the fracture site. Here is the clinical pictures where we can see the knee range of motion is good and patient is able to sit cross-legged and do squatting. So in our results, we concluded that the radiological union was observed in all the patients with a mean period of 6 months. The knee range of motion was about on average of 110 degree, with lower extremity functional score was of 73. Here is another patient who had a distal third comminuted fracture of distal femur, and patient was operated elsewhere with cephalomedullary nail. Then after the patient went into non-union, they tried to do the dynamization also, but patient ultimately presented to us with implant failure with non-union at the fracture site. We went ahead with the removal of the nail, put a retrograde nail and augmented with a lateral plate. At 6 months also we can see there is radiographic incorporation of the bone graft. At 12 months, there is union at the fracture site. Here is a clinical outcome. He had a good range of motion at the knee, as well as he was also able to sit cross-legged and do squatting. So my conclusion is when at the metaphyseal diphyseal junction, the main cause of non-union after a cephalomedullary nail is the rotational instability because due to the metaphyseal flaring. So putting a larger diameter nail, it provides a better bending stability, and while putting a larger diameter nail, we have to do additional rimming that will provide the biological environment for healing. As well as when we put a lateral plate augment, it will add on to the rotational stability by holding onto the fragments. Thus, we can ensure the osteogenesis at the fracture site. So the limitation of my study is it was a small study including only 15%. So a larger study, a prospective larger study is the need of the time to ascertain my conclusion. Yeah.
Thank you, Dr. Tapas. Any questions?